Welcome, everyone. Welcome, everyone. Happy Friday morning. I am Annie Hirano. I am one of the geriatricians with the University of Washington Division of Geriatrics. And I am here today to present geriatric and palliative care combined grand rounds. And I decided to dive into responding to microaggressions from older patients with cognitive dysfunction. So there's a bunch to cover, and I am just going to start. Let's see, there we go. So I have nothing to disclose. So what I am hoping for today is to create a safe space for discussion and exchange of ideas, because there's really no easy answers to some of these things. And it's a lot of challenging and hard work. I'm hoping to discuss the importance of knowing, having, and practicing communication tools, and actually providing some language to respond to microaggressions. And then discussing the importance of being an ally and upstander. Okay. So why am I giving this talk? Because I don't claim to be an expert on racism or racial disparities, social justice, or diversity. But I am someone who has experienced and witnessed racism, discrimination, and microaggressions. And I haven't always known how to respond in these situations. And there are still situations that come up that stump me. I am still learning, and I would like to do better. And I'm hoping that all of you will join me in this work. That being said, I know that these are challenging topics. And so a word on safety. For those who have been othered, it can just be exhausting and triggering and stressful and challenging to engage in these types of activities and conversations and discussions. So a word of warning that I will present a real case during this presentation. And I'm also going to share some of my experiences. So I just want to encourage all of us, like, if you need to leave now or at any time during this presentation, just remember it's okay to protect yourself and for all of us to take care of ourselves. So before I dive in, just taking a deep breath, these are our hospice and palliative medicine fellows having a academic year-end barbecue at my house, and I'm from Hawaii, so I made these lei po'o for them that they're wearing, and it was just a pretty joyous celebration. Okay. So that was your chance to leave. If you're still with us, again, please make sure that you take care of yourself throughout this presentation. And if you do need to sign off, that please take care and tend to your wellness. So the scope of the problem. So there has been research done on this, and relatively recently. So this is from JAMA in 2020. And I know it's a busy slide. There's a lot of information on here, but I thought it really highlighted the problem. So this was a survey of 232 out of the 331 internal medicine R2s and R3s at UCLA, UCSF, and Duke. 45% of Black and Latinx residents encountered explicit epithets or rejection of their care from patients on the wards. All 70 of the Asian residents who responded to the survey reported experiencing inquiries into their ethnic origins. So that's questions like, where are you really from? And then 96% of the women residents who responded experienced role questioning behaviors. So that's when you go into the room and somebody thinks you're a nurse instead of a doctor, or asks you, are you really my doctor? And then 87% of those women also experienced sexual harassment of some form on the wards. So the need to prioritize clinical care and a sense of futility in responding were the most common factors impeding responses to these biased behaviors that the residents were experiencing. And 85% of the residents never reported any of these incidents to their institution. 15% of residents reported belittling comments and assumption of non-physician status 1 or more times per week. So I just kind of want that to sink in a little, right? Because as Helen brings up, these stats are horrible. They're horrifying when you think about it. Okay. So the conclusions that the authors of this study came to were that patients frequently display bias, and it is mostly directed at women and minority trainees. Microaggressions, bias, and sexual harassment are prevalent in academic medicine and disproportionately affect women and minority healthcare professionals. So not surprising. And also keep in mind, these are institutions just like our own, right? UCLA, UCSF, Duke. Okay. So what are the consequences of these statistics, experiencing these microaggressions, experiencing this type of bias? So this comes from this really wonderful article again in JAMA in 2020. And I took just some quotes from the article because I really think that they're said so well that I couldn't possibly say them better. I want to bring up the idea of racial battle fatigue that was brought up in one of the studies mentioned in this article. And it's the collective impact of repeated experiences of microaggressions on one's physical, emotional, and mental health. Because keep in mind that about 15% of those residents that they surveyed experienced 1 or more of these microaggressions each week. So the quotes that I picked out were: consistent exposure to microaggressions leads to an internalized sense of inadequacy, leading to imposter syndrome in which an individual doubts themselves and their actions. Imposter syndrome can lead to isolation, affect engagement, and hinder professional achievement and career advancement, which can ultimately limit the unique contributions to the overall workplace. Women and minority physicians experience greater levels of burnout, which could lead to them leaving medicine altogether. So I would argue that these are some pretty serious consequences. And I think, we know now there's increasing evidence to suggest that cumulative microaggressions really can affect our physical, emotional, and mental health, right? This racial battle fatigue. But what are the downstream effects of that? And, the downstream effects are that larger numbers of women and minority physician leaders might leave the field of medicine altogether and no longer contribute unique ideas. Okay, so I'm going to pause there because that was a lot of heavy information. And I think I'm giving folks room to flee if they need to, like I said, because again, they're not easy things to think about. These are not easy things to talk about. And especially if you're somebody who has experienced some of these things. So what can we do? So how can we take action? So I think one of the first steps is to be able to identify microaggressions. So what is a microaggression? And you may have been in trainings before that gave definitions of this, and you probably have seen them and maybe even identified them yourself on the boards or out in the community. But I'm taking this definition. It's the same one that if you've ever seen Dr. Silk Soto give talks from the University of Indiana School of Medicine. She's fantastic. This is the same definition that she uses. And it's taken from this article on racial microaggressions in everyday life. So microaggression is an everyday verbal, nonverbal, and environmental slight, snub, or insult whether intentional or unintentional, which communicates hostile, derogatory, or negative messages to target persons based solely upon their marginalized group membership. And I like how she points out that most of these microaggressions are committed by well-intentioned, non-racist, non-sexist, non-X people, right? What I also took from one of Dr. Silk Soto's talks is that there were different forms of microaggression, and I hadn't really thought about this, but microaggressions can be further broken down into several categories, and the ones that Sue and Gerald Wing et al. Mention are these micro insults. So often unconscious communications that convey rudeness and insensitivity and demean a person's identity. And then these micro assaults, and often conscious, explicit derogations characterized primarily by a violent verbal, nonverbal, or environmental attack meant to hurt the intended victim through name calling, avoidant behavior, or purposeful discriminatory actions. And the final one is this micro invalidation. So often unconscious communications that exclude, negate, or nullify the psychological thought, feelings, or experiential realities of people who experience microaggressions. And I know I'm reading these definitions, but I think they're actually really important. Okay. And I want to name some experiences that I've had over the past few years out in the community, because I think it's important to hear from our colleagues who have experienced these things. And you saw the article and you saw the statistics I presented at the beginning. And I realized that I'm one of those statistics. So if you don't think that there are microaggressions out there, or you're still in doubt that they occur or exist, I'm going to name a few. So one of the ones that I've experienced over the last couple of years is being an Asian doctor during a pandemic, referred to as the China virus by our president. And I'll mention too that it hurt me that Anthony Fauci, who I know is a hero to so many of us, was on stage when the president was using this term, and stood there silently. And I know in a follow-up interview at one point, he mentioned that he would never use the term China virus to refer to the SARS-CoV-2, but in that moment when I was watching TV and seeing it referred to as China virus over and over, and the Kung flu, right? The Kung flu, if you all remember that. It hurt not to have somebody in a position of power who maybe had the opportunity to speak up against this, not to do so and to remain silent. And it really felt like an act of complicity. And I don't mean to pick on Dr. Fauci, because I too admire him, but it really felt like a little bit of a betrayal in that moment, if I'm being honest. And then, at one point, my family and I were getting groceries at QSC on Mercer Island, right in our community. And I saw an older white gentleman yelling, I guess he wasn't a gentleman, yelling at an Asian family who was also grocery shopping at QFC. And then I think he noticed that I was also Asian and I was there with my children, and he followed us to our car. And luckily my husband, who is white, was waiting in the car and confronted him, and he proceeded to run away. Okay. Experiences I've had at UW in Harborview. So I've had someone yell, "Hey baby, I love sushi," suggestively at me while I was walking from my car in Boren Garage to the hospital. I've had someone make, yummy noises at me when I was walking through the hallway at Harborview in my white coat, and commenting on the shape of my body. I've been told by fellow colleagues, white faculty, that when I brought up concerns about possible discrimination that I felt I was experiencing, I was told that it was all in my head. And then being mistaken for a nurse while wearing my white coat and name tag that prominently states doctor on the bottom. That's just happened too many times to remember or count. And then finally, being mistaken for other hospital staff, asked to remove patients' lunch trays or empty their trash can. And I'll mention that both of those actually happened to me this past week while I was on Veggie attending. Okay, so that happens. And interestingly, I was watching episodes of the Mindy Project, if any of you are familiar with that, and I came across this really kind of neat article breaking down this really great episode called Mindy Lahiri is a White Man. And if any of you know Mindy Lahiri, she's a comedian and she's a woman of color, and she developed this show called Mindy Project. And one of the episodes, she, I think, wishes that she could experience being a doctor as a white male. And so she wakes up in the body of Ryan Hansen, who plays Mindy Lahiri as a white man. And I often think, I thought it was a very clever episode because I too thought, what if I looked like Ryan Hansen as opposed to Ellen Williams, who I probably look more like. Okay, so those are some of my experiences. I think, again, it's just important to recognize that each one of those, right, could be categorized as a microaggression, and that they could probably each be broken down into the 3 different categories of micro insult, micro assault, and I was going to have us try to identify them, but if you wanted to go back and kind of take a look and see if you could categorize them, feel free. So now, once you've identified a microaggression, what's the next step? And so one of the frameworks that Dr. Soto discussed is when you see a microaggression, when you experience a microaggression, maybe just me listing some of those experiences, maybe you yourself have had some of those experiences, maybe you have witnessed colleagues having some of those experiences. It's important to think about your reaction versus your response. So I was trying to make this a little bit participatory so nobody gets too bored. And I realized I missed a comment by Angela.
Oh, yeah, I just had a really quick question and clarification.
Mm-hmm.
So if a generic undescripted person is walking down the street and another person just starts screaming at them like, I'm gonna kill you, with F words and stuff. My understanding is that that doesn't imply a threat of violence. So maybe that's a bad example. But my understanding is that's actually a misdemeanor. Like in most states of the union, you could actually get arrested. So there's no micro. I bet it's straight up aggression. And but there's no threat because of who anyone is. It's just literally like someone threatening a stick figure threatening another stick figure is aggressive. So when I read your examples, which are heartbreaking, by the way, it almost seems like because they're coming from a place of racism, we downgrade them to a microaggression. But to me, those are misdemeanor assaults. And so why, like, I don't know. That's a thought that I had in my head and I just wanted to share. Because they're targeted, they're downgraded. But if you just yelled at a random person and he was blind and didn't know what you look like, he could be arrested. I don't know. That seems kind of weird to me that we carve these things out in these ways. And then just on the flip side, in other ways, I mean, I think we're getting better at this where we are, if someone spray paints a building with a, sunflower, yeah, that's great. Sorry, it's still vandalism. If you spray paint it with a swastika, you get added charges because we recognize that the threat of that is much worse. So I think in some ways, hate crime legislation is getting better. But like, to me, some of those things weren't microaggressions. They were straight up assault and like violence. So I don't know. I don't like the word microaggression because I think right wingers use that term and slam it back in our face and make fun of it. I just want to call it being mean, being rude, being racist, but that's my personal opinion.
Yeah, I think those are all very fair comments. And I think, yeah, sometimes some of these things I just want to call outright racism, right? And it doesn't feel right to assign, the prefix micro to any of it. And I think that's where kind of language matters too, is can we come up with better language to identify and describe some of these things?
Yeah, and I do think it's useful to think of a lot of these things in a big category because they are stemming from the same seed. But I think it is a very different thing when someone accidentally or on purpose mistakes us as nurses, which I'm like an old man thinks we're a nurse or whatever. I don't know. That is to me characterally different than someone yelling in violence. Like I do think, one makes me feel very unsafe and one makes me roll my eyes. So I do think that language does absolutely matter. But when someone's moving into that realm of making someone feel unsafe and violent, I don't know. I do think we need to call it out for what it is. That's again, yeah.
Yeah, I agree that there are probably, gradations to the level of injury and offense, right? Because I think, you and I probably as women, like being mistaken for a nurse, being mistaken for environmental services, being mistaken for, one of the dietary services folks, it happens so often. So that one's pretty like low on the I guess scale for me of those I can probably just toss off at this point, but is it just because that I've gotten so used to them too? So it's such a personal thing, right? I think too. And if you're somebody who just doesn't experience as many of these things on a weekly basis, then maybe, it would be a big thing if it happened to you. But for folks who experience it frequently or regularly, like there definitely is a scale, and that one I feel is kind of low now, right?
Yeah. And I'm not saying to minimize the things. I'm just saying we need to call out violence when it's happening. And I think we're minimizing violence because it's happening in this context. That's all I'm saying. I'm not saying to minimize the other thing. I'm saying to maximize the violence. Like
I agree. I hear you loud and clear.
Violence. Thank you.
Yeah, no, great points all. Okay. In the interest of time, I am going to kind of move on here. I wanted to clarify kind of the difference between reaction versus response. And I was going to have you all write in the chat your thoughts about reaction versus response, but in the interest of time, I'm going to give you some answers, and then I'm going to have you use the chat on something more valuable later on in the presentation. So the idea is the reactions are sort of in the moment, quick, kind of your heart and your body, maybe that adrenaline spike. So your initial reaction to what you've seen, heard, witnessed, experienced. And then responses are what we think of as things that require thought and more contemplation. And we think of them as the more like brain or head response. And it requires you to be proactive, right? In order to have a response, it actually takes time and practice in using some of these communication tools. And so what I'm hoping to do today is focus on the response, right? It doesn't mean that the reaction is I'm not trying to paint the reaction in a negative connotation. It's not bad. It's, it's also what we feel in the moment, but to distinguish it from the response, which is what we're going to work on today. Okay, so what does a response look like? And so just like, the opposite of the micro aggressions, micro insults, micro assaults, we have the idea of micro resistances. which are small scale, individual and or collaborative efforts that empower targeted people and allies to respond to microaggressions. So self-care, showing up, talking about it, and using these communication strategies. And we also have these micro affirmations, which are tiny acts of opening doors to opportunity, gestures of inclusion and caring, and graceful acts of listening. So using active listening, recognizing and validating experiences, and then affirming emotional reactions. And what I love about this framework is that all of these things are actually palliative care strategies, right? So for those of us who practice palliative medicine, these are all things that we encourage and we practice with our patients, with each other, with ourselves. And there are a number of communication tools and strategies that have been and are being actively developed to respond to racism, discrimination, and microaggressions. And of note, there's Open the Front Door, which I think is kind of a nice one, as well as this one that's adapted by Dr. Silk Soto, where she introduced a W to it, which is kind of like a why question. And then there's these slightly longer ones that were also developed. And you can see they're all acronyms. And I will have links sent out with access to all of these tools. I think for our purposes today, I did want to kind of present something a little, a slightly simpler framework for us to work with, because we have specific challenges for our patient population, right? Because these tools are really made with the assumption that your patient is cognitively intact, is able to think abstractly and reflect a little and engage in a conversation of that level with you when you're responding to their microaggressions. Our patients, however, sometimes don't have quite that ability or that range. And so from just a literature review, I could not actually find any tools or communication strategies for responding to people who have to microaggressions from people who have cognitive dysfunction. And there are some being developed for palliative care patients, which I've given a previous either grand rounds or town hall on. And that's also a unique population, right? Because oftentimes when we are seeing our palliative care patients, we're actually trying to build trust and rapport, and we were consulted because maybe trust and rapport had been broken and we're trying to restore that. And so we might have a little bit more trepidation engaging in calling people out and responding to microaggressions in that population as well. But for today's talk, I do kind of want to start focusing in a little bit more on this category of folks who have cognitive dysfunction, because really I have not seen any tools developed or being developed yet. And that could change for those of you who go to AGS. Please bring back any tools you find or learn. But I really wasn't able to find any out there on the web or in the medical literature. Okay, so for this patient population that I was talking about, what is the first step? So you now can identify microaggressions. You were either on the receiving end or you witnessed it. What's the first step? And I will tell you that the first step for me as somebody who has been on the receiving end of microaggressions, and sometimes quite regularly, is actually to decide whether to respond or not. Because I don't respond to every single one. And honestly, like I'm always actively weighing the effort or risk of responding against the psychological pain or harm that might come later if I don't respond. So the question I'm actively asking myself in the moment is, will I regret not responding? So if I don't respond in this moment, is that going to then, weigh on me as like this psychological pain, harm, or regret later? And then it becomes a little bit more challenging. So if my patient has delirium or dementia, will they even remember? So who am I responding for? And I would argue that I'm responding for me because again, I'm weighing whether or not I will regret responding in that moment, and what burden I will carry if I don't respond in that moment. And so I would ask, for folks like, does it matter, right? Um, and Tiffany, I see a great comment in the chat from you. Did you want to unmute and share, or let me read it? Oh, Tiffany's on the bus. So if it's okay, I might just read your comment that, yeah, I saw an older Chinese man with cognitive impairment in clinic the other day, and he asked me, "Are you from China?" And I didn't know how else to respond except, "No, I was born here." More difficult when from your own community and there's memory impairment. Harder to remember in the moment. You can always defer the question and say, let's focus the care on you. So wonderful. So Tiffany's already starting to kind of give us some communication tools and strategies in how to respond. So again, I think it's kind of a wide open field here. So part of this presentation is to kind of see, like, what have you seen? What have you found to be effective in responding to these really challenging situations where there's a lot to be weighed and a lot to think about? And then Mike is asking, could you discuss how to be an ally from a position of privilege? Absolutely. So I think we'll definitely get to that. I am going to come back to that and kind of continue on for now. So, okay, if you decide to respond, it's important to kind of do your own internal temperature check. And again, kind of just, think about your reaction, because, right, your reaction is not necessarily your response. But we're human and we react to these things. So I always try to just take a deep breath. And I try to ask myself, like, ooh, how upset am I? Or how uncomfortable am I? Or how worried or nervous? And then again, I try to maintain compassion for myself, for my patient, for their family member, and for anyone else in the room with me, because engaging in a therapeutic relationship is vulnerable and challenging. And again, part of my compassion for myself is deciding whether or not I actually even want to respond. Okay. But we're going down the pathway of responding. So one of the things that I've actually had to practice is politely interrupting patients or family members who have made responses, because I am Asian. And so my first inclination is always to apologize and say, oh, I'm sorry, can I interrupt you? And really, like, I'm not sorry, I am interrupting a racist statement or a microaggression. So I've taken that out of my vocabulary when I'm using these tools to respond to microaggressions or challenging behaviors. So instead, the one that I practice is, I'm going to pause you there. And then describe the problematic behavior. So you called me your nurse, but I'm your doctor. And then you can either share how the behavior interferes with clinical care, share your concern regarding the behavior, or clarify your role. So I do this every so often where I just practice it, because I have lots of opportunities to practice this one. And I say, I'm here to talk to you about your medical care and the plan for today. And then you can set limits or make specific requests. So let's get back to talking about how your pain is doing. So getting back on track. So you can address it, right? And I feel oftentimes better that I have addressed it, or that I've practiced this tool in the moment, because the more you practice, the easier it gets for the words to just come out. It's like muscle memory. So it is important to practice. And like I said, I've practiced these things actually in my head, because I've been in situations where I've been struggling to reach for, something respectful, polite, and yet firm to say in some of these situations. It's like vital talk, that practice and those drills. Okay. You can also use your palliative care skills or your geriatric medicine skills of active listening and acknowledging emotion, right? Acknowledging the patient's emotional response. So, oftentimes, like I said at the beginning and the outset, the person who might be committing the microaggression is not necessarily coming from a place of ill intent. And so, they could be, if you do choose to respond, the emotional response you could get back is one of embarrassment or stress or guilt. So it's okay to acknowledge like this situation is frustrating. And then always try to avoid getting into an argument if or when the patient denies or attempts to rationalize their behavior. So just kind of at the outset saying, I know you didn't mean to make me uncomfortable, can sometimes help cut that off. If behavior continues, it's okay to be a broken record. And for all of these interactions with our cognitively non-intact patients, using as few words as possible is always the best. So please do not comment on my ethnicity. And then set limits with consequences if necessary. If you continue to comment on my ethnicity, I'm going to step out now and come back later. And I recognize that as a physician, as long as my patient is stable, that's actually a privilege for me that sometimes my nurses or aides don't have. So again, we can talk about how to be an upstander and the importance of that. But again, sometimes you might be in the room with colleagues who don't have that privilege, and it's important to speak up even more in those situations. I'm just catching up on a couple of the chats. So Barbara says, as a tool for elderly, humor at the error, nurse versus doctor with reminders of our mutual humanity has been helpful. Although racism comments are harder. Also history, I really admire Florence Nightingale. She taught physicians so much. I am honored to be mistaken for a nurse. Same, I think it's not so much, that I am not honored to be mistaken for a nurse. But when I am wearing my white coat and my name tag says doctor, and they are calling my medical student who is a white male doctor and referring to me as their nurse, it's a little challenging. Okay. For cognitively impaired patients, again, just general rule of thumb, use as few words as possible in as straightforward terms or language as possible. And then, this was a framework that was actually developed by Nicole, I'm blanking on Nicole's last name, who was one of our psychologists at the VA Puget Sound. And these were some steps that I've modified that she actually gave to me and our team when we were experiencing some of these interactions and were reaching for tools to intervene. So this is a little bit of her legacy as well. But I've tried to kind of really limit them down into a few steps that can make it as easy as possible to come up with responses to these situations. Because again, a lot of the tools that I've found are a bit longer and don't always have the language that I'm looking for or that I would use to respond to our specific patient population. Okay. Okay. So again, you may need to abridge even further. So the steps that I just talked about might need to be condensed down even more. So for example, you might find yourself interrupting, setting limits, making a request at the same time, or interrupting while clarifying your role and making a request at the same time. So really just kind of abridging the steps even further, depending on your situation. Okay. So how are we all doing? Yes, thank you, David. Nicole Torrance. She's just fantastic. And she helped develop a good part of that framework that I just presented, though I abridged it a bit for our patient population. And again, you'll see you might need to abridge it even further when you're responding to certain situations. Okay. I am going to ask you all to open your chat boxes and get them ready because we're going to try a case together. And I want to emphasize that there are no correct answers here. There are no easy answers here. This is just something to kind of get the thoughts and ideas flowing, and nothing better than a real life case. So this actually happened to me on the medicine consult service this past week. And the details have been changed to protect patient confidentiality, but you are attending on the geriatric medicine consult service and are following a 71-year-old woman who had a mechanical ground level fall. She didn't hit her head, she didn't have loss of consciousness, but she did sustain a left humeral fracture and is now awaiting surgical fixation. And yesterday when you saw her, she was very pleasant, chatting with you and oriented. And today you are called to bedside because she has pulled out her peripheral IV and is now making, per the secure chat and Epic, paranoid statements. Her vital signs are stable. She is oriented ×4 when you go and see her. And when you speak to her, there's no psychomotor agitation. There's no pressured speech. She's sitting up calmly in bed. And your resident, who is East Asian, a nurse who is Vietnamese, and an aide who is Ethiopian are at bedside. And I know all of their backgrounds because I am friends with the nurse and the aide. And when you enter the room, the patient calmly tells you, "You're all trying to kill me. I know you're trying to poison me. I know I'm not supposed to say things like this, but these three are women of color and I don't trust them. I want my doctor at Swedish. He would know what to do." Okay. So you are you in this situation. I was me in this situation, but you are you in this situation. So where to begin? So anyone who feels comfortable, feel free to put any initial thoughts in the chat. How do you feel, right? What is your reaction? So this is the reaction part. What is your reaction? Tiffany says, yikes. Yep. Barbara says, unfortunately, I think as an older white woman, this might not have happened. And Stephen says, disempowered. And David says, dumbfounded. Is this a microaggression? I see some yeses, macroaggression. And Angela says, definitely go see the patient, need to assess for psychosis, need to support those nurses, need to talk to the patient about how those statements are not appropriate, maybe get some context from family. Is this out of the blue? Could actually happen with paranoia, or is it her personality? Yeah, those were all things I was asking too. And Tiffany says, feels like outright racism rather than a microaggression in my opinion. Yep. Surprised she said women of color and not foreigners. Yeah, isn't that interesting? She specifically said women of color. You three are women of color and I don't trust you. And she had the insight to say, I know I shouldn't say something like that, or I know it's not right to say something like this, but she said it anyway. Nosley agrees it's a macroaggression. Angela says, unpopular opinion, Ambien doesn't cause racism, but paranoia can bring on weird things that aren't real. Yeah, and Shelley says, I don't think a microaggression, as I understand, used to be unintentional. This statement was intentional and racist. Oh, so that's a good point. So remember, one of the categories of microaggression was micro assaults, and those can be intentional. But what an interesting thing, right? To have some insight into, I know I shouldn't say this, but I don't trust you people of color and you're trying to kill me, specifically you women of color. Okay, so.
Hi, Annie.
Hi.
Hey, yeah, it's Chris. I'm pretty sure I remember this day because I know the resident involved, and I had to leave for clinic, so she wanted to staff that presentation to me before I left too. But I thought that her debriefing how she felt about the experience, which again is separate from like her initial whatever gut reaction she might have had, or how she debriefed it to me sounded appropriate. Where it's like the instinct that we get from experience as because you're a doctor is like, okay, I know this is delirium. I know where her retention component or like the delirium cause is, but I'm not sure what she said, but she said afterwards that like the best that we can say is like, I'm sorry that you feel this way. I know that you would like to see a separate doctor, but we are your healthcare team right now, and we would like to take care of you. I think that was like a rough estimate of what she said, but I'm not sure if that was close to what you were.
Yeah, so wonderful segue, Chris. So for those of you who decided to respond, how would you do it? And feel free to pop in the chat like language that you would use.
Hey, this is Angela again. I mean, just to, reflect on my statement about, Roseanne, Ambien didn't cause your racism, my dear. But, being in MedG attending for the last however many years, I can tell you firsthand, we all can, that we have definitely had patients whose behavior is very, very different when they're delirious than when they're normal, when they're not delirious. So for example, a very combative patient who is ripping out their IVs. And it doesn't always look digital and black and white in terms of like a delirious patient will always be completely loopy and think they're on Mars. That's not true. They can look sort of quote unquote rational. Okay, so I just caution a little bit in the, she's clearly racist and watches, Gone with the Wind every day. Like, I don't necessarily think we can make statements about her. I don't think we know enough about the situation to make any kind of judgment statements about her state of mind until we go see her and get more information. Although it does sound, I mean, her statements are super unfortunate, and they draw from her experiences and things around her, just as if she might have said, I want to kill myself. I want to stab myself with this needle, even if she's never been suicidal before. Or I want to jump out of this window because I hate this hospital that's on the moon. When she, so I just, the second two statements are scary, but they don't hurt us. But the moon and the suicide. But the statement that she did make hurts other people. And I just want to caution, and so here's what I would say, and this is where I'm a brain doctor, and so I think about this way, way, way too much on my way into work. I think all isms come from our brain, and they're all like this at some level. Like racism comes from is a disease of the brain. And in this case, it's maybe an acute disease of her brain, and she's manifesting as racist statements, which is really, really, really unfortunate. And so she did a racism for sure. But I think we want to just be really careful, and like, if she really isn't rationally doing this and she's totally out to lunch, then I think, just that's a different response than if she's truly, saying those things, quote unquote, rationally, which, I mean, racism isn't rational, but I don't know if I'm making any sense at all. But if she thinks she's on Mars, and do you know what I mean? Like, then you're not going to rationalize her out of anything. You just have to take care of her, and then take care of the nurses too.
Yeah, but could we add a broader context? Because I don't know if Annie or those of you who do Med D agree with me, but I find some of my scariest interactions are on Gen Med wards. Not that the Geri patients can't do things like this, but they're not 35 years old and on mind-altering substances yelling stuff at you. So I just want to say contextually, I find. I'm not saying I'm more comfortable when things come up like this on the Geri patients, but I guess I'm more comfortable. I don't think the word is comfortable, but you know what I mean? It's a different, to me, I frame it a little bit differently when it's coming from a 90-some-year-old who's had life experiences that have not excused them, but framed them for this type of behavior, versus someone who's got brings other problems to the table from the younger cohort. So just pointing that out, because everyone keeps saying Med G, and I'm like, no, I think I'm a little bit more nervous when things happen with younger folks for a variety of reasons.
Yeah, and I think it brings up a good point of distinguishing, right? The harm that this patient is causing is through racist statements, right? And so it's more of a psychological harm, and the patient might be delirious. The patient might have something else going on. But I would say, what I was concerned about in that moment, right? The patient's vital signs are stable. She's getting the care and the medications she needs. And we will figure out, that's part of our medical plan for the day, is to figure out, is she delirious? If she's delirious, how can we mitigate that? But in the moment, there are colleagues in that room with her who she has made racist statements against, and one of our learners, how do you respond to that, right? Like, how do you, right? Because if we're saying she's delirious, right, I would go back to my other questions, like, does that matter, right? Does that matter? Does that make a difference in whether you respond? And there are other people involved in this situation that might be hurt by these statements, right, who are in the room with you. And I like the comments coming in of, this is David's, that sounds very difficult for you. All of our team members are highly qualified professionals, and we're here to give you the best possible care. David, like, I wrote a response to this question, and that's like verbatim what I came up with, because I didn't want to be unfair and make everybody come up with responses and not try to come up with one myself. But yeah, like, she's scared, she's frustrated. So responding to her emotion, that sounds really like frustrating, or that sounds really scary for you. All of our team members are highly qualified folks who are here to give you the best care possible and to help you recover from your injury. And again, I too put in a statement that please don't make comments about team members' race or ethnicity. And David put it more nicely. I asked that you not make comments about the color and sex of our team members. Can you do that for me? And that's very similar to one of the responses that I came up with using the framework that Nicole Torrance, Kira Schreiber, and I kind of came up with together for this. Okay. Really great comments. Okay, so again, if you are an attending and you are white or white presenting, And particularly if you are a white male and you have witnessed this, checking in with your colleagues, I think, is really important, right? Because there were 3 other people in that room who were all women of color, who all heard that too. And so how do you be a good upstander ally? And I think just first of all, acknowledging, like letting them know that you saw, heard, were witness to this behavior, to what just happened there. And you know, saying something along the lines of, I'm so sorry, I heard what she said. It was terrible. How are you feeling? And check in, right? And all of you are, I know, compassionate, lovely folks who can come up with your own language around these things. I think, you know, letting the person know that you saw and you heard and you were witness to this, and then checking in. And then further check-in or intervention might include things, different things, depending on whether the other person is a trainee or if they're a staff. Right, because like I said, you know, as physicians, as long as our patients are relatively stable, we have the privilege of leaving the room, whereas some of our colleagues might be more actively involved in care and not able to leave as easily. So consider helping them access support resources that they may or may not know about. So UW has the bias reporting tool, the bias navigator, or you can connect people with bias navigators. Shanitra from our division is training to be a bias navigator, pointing them towards their manager or supervisor. And then for trainees or learners, I, as an attending, I will just offer to, you know, see that patient if they feel too uncomfortable, or just don't want to have to deal with that in their really busy, already stressful residency. Just one more thing that they don't necessarily need to deal with, right? If I'm willing to see the patient, because I have to see the patient anyway, because I'm the attending. Okay. Last things, because I'm running out of time, because this was a big topic, but for learners, trainees, and members of your team, it's important as, you know, an attending or as a leader of a team or as a member of a team to be proactive. So when you start a new service, or maybe checking in when you are orienting your team, you can ask whether people feel like they have the tools necessary to respond to microaggressions, and you can ask their preference on whether they would like the opportunity to respond first when they are witness or on the receiving end of this, or if they prefer you to help intervene. And here's what that looks like, because I saw it modeled so well by one of my senior residents on Med D. And it's as simple as this. She came on service and she was orienting the new interns, because they had all just rotated. It was the top of the month. And she said, we treat patients from a number of different backgrounds, and we might encounter racist comments or microaggressions. Do you all feel like you have the language and tools to respond to this if you choose to do so? Let me know if you don't, because I would love to review some strategies together. Also, let me know if you're someone who would want to try addressing the patient yourself first, or if you would want me taking the lead if we're there together. Less than a minute, and it was amazing. And there was my team. So I was on service, and we had an all Asian team, which we were really proud of. And we had a great time. And we encountered a few microaggressions, but we were able to respond to those. So thank you so much for joining me for this talk. I know that was a lot of information and a lot of really fantastic comments from everyone. Thank you for being so engaged. I know there's so much more we could talk about, but an hour is probably just not enough. So please utilize the QR code. Feel free to give me some feedback. And yeah, I welcome comments, and I think I'm out of time, but I'm happy to stick around if there's like a question or two or any last comments. Oh, and the last thing I will mention before Diane signs us all off is we are going to send out an email recruiting folks who are interested in diversity, equity, inclusion, and social justice work within our division. And anyone is welcome to respond to that email. We will collect the names and emails, and we'll be sending out some resources, and we'll try to find a time where we can all just get together and start talking through what we might want to do division-wide. So thank you all again.
Thank you, Annie. I'm sorry that those things have happened to you.
Oh, well,
Not
thanks, Angela.
Just, I had a quick question. You said you were going to stay on for a minute. You know, one thing that I've noticed, you know, if you have something that's a big issue, you know, I had a patient at Memory Brain. Long story short, I had to report, and it was awkward and awful. And actually my staff was really supportive, but and maybe this would be a good chance to jump on that committee that you just mentioned. But one of the things that I was frustrated by was just kind of a lack of, like, everybody was like, well, I don't know what to do here, and maybe you need to call this or that or the other place, and like a lack of consistency and protocol. And this was like stalking behavior of a patient anyway. You know, I ended up doing way more work and having 6,000 Zoom meetings about this whole issue. And I had to be present at everyone and account my abuse to like more and more higher ups. And I just thought that was, and I'm a pretty strong person, so I just did it, but
it was re-traumatizing.
I was re-traumatized every
Yeah.
single time. And one of the reasons I was so re-traumatized is because it reminded me of an ex-boyfriend that stalked me. That was the more painful part. The patient part was like, meh, whatever. But I had, you know, and I didn't always bring up that part, but like, you know, systems in place for, like, if someone is traumatized, like, can someone else take it on their behalf? Like, if you're if you're suing someone, they go to court for you. You don't always have to be there for the preliminary injunction or whatever lawyer talk, blah, blah, blah. You know, you have to go to the big court, but your lawyer can file briefs on your behalf and you don't have to be there. And I was just thinking, like, do I really have to be there? Or like, could I have just written, you know, if I had to do it all over again, I would write up my statement and Carrie Barbie could have just read that into the record every time. I didn't want to explain like my stalking story to some, you know, man in it.
Yeah.
It was awful. And so anyway, you know, and so to re-traumatize a resident is like, had to explain, like, yeah, I was called the N-word by this guy. Like, they shouldn't have to do that over and over if they have to report this. So I don't know. That was just something that I was thinking about as you were recalling these stories. Is there a way to have someone else come in on their behalf and be like, I'll report this for you? Like, so if there are reportable events.
Yeah, I think that's a really good point.
You know, because constant meeting and talking about I don't know, sometimes it's helpful and sometimes you just want to get on with your day. The other thing I was thinking about is like all of the like compassion and concern and all the time everybody spends with the 70-year-old lady. I think all of that time could have been better spent talking to management. She's delirious. She's not going to remember. So like, what is management doing to help with problem patients, particularly on like general medicine, like our really malignant narcissist patients who split our staff and consume our patients or our residents' time, resources, and brain. Like, that's a bigger problem to me. And maybe that's my opinion. So I mean, I'm not the be all end all of that, but they're all important. I mean, it's all important and it all traumatizes us in different ways. But I just think that, you know, there's time spent and then there's time spent that goes somewhere.
Hey.
Hi, May. Oh, are you muted?
No, I'm not. I just had a quick question, but are you done, Angela?
Yes.
I had a quick question to the audience. I had a fellow come up to me and a senior care clinic patient who was who was in their 80s and not cognitively impaired. Well, maybe slightly, but nothing. Who couldn't stop talking about how attractive she was. So it was like she was a woman of color, so she was prepared for that type of thing, but not this type of thing. And I was just wondering, I mean, it's still a microaggression, right? I mean, because they're commenting on, and he wasn't saying anything. He was specifically referring to like eyes and face, like, so it wasn't, anything like, Anyway, I just did. I didn't have a framework for that one. So if any of you all had that.
Yeah, I think that comes up a lot actually for some of our younger, right? Like we have a lot of young women of color residents, fellows, and so and med students, and I think, and nurses and aides, and I think, for again, I think the framework still holds for that is, checking in with them and seeing, do they want to respond to it? Would they like one of us to respond to it? And then if the patient's stable and they're not the only person who's responsible for the patient, if after we respond to it, the behavior doesn't stop, can we just, for the psychological safety of our trainee, can we take them out of that situation, and again provide the appropriate supports for them that we can. But I think if it's against one of us, where we're the attending, and maybe maybe we have a colleague, if we feel so uncomfortable, maybe we have a colleague who can step in for us, so that we can tend to our own ourselves. Or again, you can be a broken record. You can just repeat the framework, and say, please stop commenting on my appearance. Let's get back to your care. Please stop commenting on my appearance. Let's get back to your care. If you continue to comment on my appearance, I'm afraid I'm going to have to cut this visit short. So the framework is there to try to help, but I appreciate that it's not one size fits all, but it's there to try to at least provide the scaffolding for some of these situations.
Yeah, and I mean, your data, your very first slide, Annie, showed that we need to build this into training. I mean, just like we do chest pain eval. We should all be good at this, right?
Yeah.
But we're not. We don't talk about this kind of stuff. And places are actively trying to discourage talking about this kind of stuff.
And it's hard to talk about.
This conversation is illegal in Florida. I hope you don't send it there.
Well, it sounds like it'll be available on YouTube, so.
Oh no, you're gonna get a cease and desist order from DeSantis.
I had one funny experience I wanted to share. This is Barb Harper. I appreciated your talk, and I was really glad somebody pointed out, maybe I was confusing. I was horrified that in a way, like I feel guilty / sad when, I'm with colleagues of color. And what I meant by being an older white woman is I know, and it's another reaction within me that goes, that might not have happened had I been there, because I think that woman was an Anglo or a Caucasian, and they would have seen me, and that would have quelled maybe that delirium a little bit. Who knows, right? I wasn't there. But so that was my reaction. I had those two reactions. Oh, that's horrifying, but not surprising. I feel guilty. I don't, these people don't deserve it. This is, nobody deserves this. But anyway, I do remember, I've always wished, since this happened to me about 10 years ago, and I've always thought, oh, I should carry a stuffed animal when I'm in my bag, and to keep in my coat when I visit men, because I had it was an unpleasant experience, and I just handled it by turning to the daughter and wife and saying, I think that points to his impulse control and inability to know and to his mental status. So this man said, "Oh, your breasts feel really good, right?" Because I leaned to take his heart, to listen to his heart, and I've always wished that I could have pulled my favorite little hedgehog stuffed animal out of my coat and said, "Oh, you must mean Harvey." So, I mean, I have kept that in my head. Like, how do I prevent that kind of thing? Don't get that close to a patient that's male. Recognize that that might happen, and and prevent it. That's what I do now. But I still wish I had that stuffed animal to come out and say,
Oh,
you're
I'm so
confused
sorry
old.
that happened to you.
Well, you know what? It's
Horrible.
made me more aware that, of my placement. So I take it as a learning curve. I had plenty of stuff happen in residency that was ignored,
Yeah.
even by psychiatrists. Oh, it's just like, if I had I had a GI attending with a psychiatrist's wife that he said he admired, but yet when I complained about the male residents, he said, it was more than downplayed. I don't need to go into it, but it was like, "Oh, here you were, we so appreciated your ability to get here in the ice, and now you're saying this." And I'm like, "You are not really." I just left. I said, "Well, I thought you, of all people, would understand because of his
Yeah.
psychiatrist wife." But anyway, so
Yeah, those are all microaggressions that you were
oh,
experiencing,
sure,
right?
no, yeah,
And they've left trauma, like lasting trauma. And I think that, thank you for being vulnerable and sharing and just highlighting, I think the really destructive nature of these things, right? That we carry with us, because they are hard to let go.
oh
You
yeah, they
remember
don't
them.
leave
You
you,
remember
right?
them. You don't, yeah, they don't leave you. You don't forget.
They
So
can help. I do think that it has made me more aware of, like, my reaction. Like, okay, this is happening. What can I and sometimes I don't even know if some of the things I say are totally accurate. Like, if I've explained to and I would love to know, like, I've explained to patients who are concerned about like the care they're getting from a person of another country. And I said, "Do you know that in their country, caring for people is a great honor and well respected?" And I have found that to be, I'm very comforted by their presence. And I'm speaking of Ethiopians, but that I've worked with, that I've had to say that to people. And I resent that I have to say it, but I think that was what my historical perspective is. It's like, I want to change their framework. I'm not sure you can do that with people who are demented, but you can try.
yeah, I think, one of the takeaways is, we can't necessarily know or change our delirious patients, our patients with dementia, or cognitive dysfunction. We can't necessarily change them. We can't change these things that they've grown up with, that are so heavily
Yeah.
like, part of their thoughts.
Yeah.
But we can protect each other a little, and we can stand up for each other, and
Yeah.
we can use these tools to check in with people who are on the receiving end of those microaggressions. And we can try, like I said, to use the scaffolding to shut down those behaviors. And we may or may not be successful, but even in the act of trying, our learners, our colleagues are witnessing us standing up for them, and that means something.
Yeah, no, it's healing. It is.
Yeah, and you're pulling out of that stuffed animal. I think of that as like secondary prevention. I think we need a lot more primary prevention, and I think we're doing that with how we're raising our kids better to respect all genders and all of that. But we have a long ways to go. So guess what year this was? A Boise State professor said that women going into medicine were medicated, meddlesome, and quarrelsome, and women shouldn't be doctors.
Oh,
Guess what year that was?
last year?
Boise State.
Was
Yeah.
it last year? During
2021, the end
Yeah.
of 2021. And the response of the Boise State president was like, "Well, he's got free speech." They needed to stand up and go, "This guy is an idiot." Like, until that kind of stuff happens, and until like active misogyny and homophobia and bigotry aren't just called out and completely, like the Boise State, in my opinion, the Boise State president's response to this guy should have been so laden with F words you couldn't put it on CNN. But no, it was pablum. It was like, well, you know, he has free speech. Come on, grow a pair of you know whats and say something about this sexist guy.
Grow a pair of ovaries.
That's what I was, that's the word I didn't say. Yeah, so
I have to, this has
anyway,
been great. Thank
so
you.
that's
for-
when we get mad at this 70-year-old lady, use that passion to yell at the Boise State professor, because I think that's where our power lies, is in political activism rather than yelling at her. That's just my last, get mad where it counts.
And use your communication tools. So
Yeah, and raise our kids better. And you
hopefully
all are
that
doing
helps
Yeah.
provide a little bit of
Thank
of-
you for, I'm really sorry those things happened to you also. And I
Yeah.
do, I'm,
Sure.
it's just, and I would like to be included in that group of all Asian residents and fellows and have fun too. Because I really love having fun with money cultures, because it's so interesting and it's made life so much more, it's so much richer.
I want to thank everybody for sticking around, and I know we could continue to talk about this all day. And
Yep.
hopefully we'll have more of these
Thank
opportunities
you.
because I think we have a lot of work to do, right? So, and we
Yeah.
can accomplish great things together. So thank you again. And
Thank you for the
sign off
reminders.
now.
Good night.
Bye.
Good night.